All righty, guys. Thank you so much for joining us this afternoon or evening, rather, depending on where you are in our United States. Well, I am Asia Lee. I'm the Director of Patient Education here at the Arthritis Foundation, and I am so thankful that you are here joining us today. On behalf of the Arthritis Foundation and the American Kidney Fund, we are pleased to bring together two vital areas of healthcare, rheumatology and nephrology, to address the connection between chronic kidney disease and gout. Both conditions affect millions of Americans, and research has shown a significant overlap between them. Gout, a type of arthritis caused by elevated levels of uric acid, can exacerbate kidney problems, while chronic kidney disease can in turn increase the risk and severity of gout. So today's collaboration highlights the importance of an integrated approach to patient care, recognizing the expertise of rheumatologists and nephrologists, and offers a unique perspective in managing these interrelated conditions. Together, our organizations provide comprehensive and complementary resources to help patients fully understand their healthcare needs, from symptom management to long-term disease prevention. By aligning our efforts, we aim to empower patients with the information and tools necessary to improve their quality of life and navigate the complexities of managing both CKD and gout. We're excited to share valuable insights, and we look forward to helping you connect the dots between those significant health issues. So we are going ahead and get started on tonight's program. So just to give a few housekeeping rules, all attendees have been muted. We want to make sure that our speakers aren't distracted. We want to make sure that they can focus on giving the most quality information to you as possible. Please use the Q&A function at the bottom of the screen. So at the bottom, you'll see a bar that says Q&A. You're more than welcome to submit any questions that you have. Our speakers will be monitoring the chat throughout the presentation, and your question may get answered at our Q&A at the end of the presentation. You also will receive a post-event survey. So sometime soon after the presentation, tell us how we did. Tell us what you learned. Tell us what you like. Tell us what you would like to learn more about. And as always, this will be posted on our YouTube page, youtube.com/Arthritis Foundation. You can find this webinar as well as other resources there probably about next week. And you always can go to our arthritis.org/webinars page to see some of our other presentations. So what we're going to go ahead and do now is launch a poll. Before we get started, we want to know what aspect of gout and kidney care are you most interested in learning about today? So on your screen popped up a poll. Go ahead and answer if you're able. All righty, it looks like more so than not, you guys are interested in learning about causes and risk factors, symptoms and diagnosis, treatment options, and prevention strategies. So we appreciate that. But without further ado, let's meet our wonderful subject matter experts. So we have Dr. Thomas Rennie. He's a rheumatologist at Rheumatology Associates of South Texas. So if you're in South Texas, check him out. He specializes in gout, lupus, and overall arthritis care. He is up in the corner right there. Give us a wave, Dr. Rennie. Awesome. Thank you so much. And then we have Dr. Jamie Green, Associate Physician of Nephrology at Geisinger Health System in Pennsylvania. Her specialties include internal medicine and kidney care, and she is our other subject matter expert. Wonderful. So let's get into what you should expect to learn today. So we're going to define gout, understand the common symptoms, and dispel common myths about the disease. We know that sometimes we hear gout and we don't really know what's going on. Today is when you'll find that out. We'll explain the connection between gout and kidney care because there are so many, nuances that connect the two. Identify risk factors for developing gout and kidney problems, as well as the importance of early detection and treatment. And finally, understand the role of preventative care and identify resources available for affected individuals. I apologize. But without further ado, let's bring Dr. Thomas Rennie to the stage.
Well, good evening and thank you. I tell you what, I absolutely love talking about gout. I think that gout is a fascinating disease. And one of the reasons that I like gout is we know how to treat it. We can successfully treat gout, prevent you from having any more gout flares, and prevent further destruction of your joints. So what is gout? Well, gout is a type of arthritis that's caused by the buildup of uric acid crystals in your joints. And we're going to definitely talk some more about the uric acid, but it's more than just joint pain. Gout is a chronic, destructive, inflammatory type of arthritis. As a rheumatologist, I've seen all types of arthritis. And the worst arthritis I've ever seen in a patient is in somebody who had undiagnosed and untreated gout. The gout just completely destroyed their joints. And in fact, when we did x-rays, they didn't even have joints or even bones. They just had bone fragments and then tophi, which is an accumulation of the gout crystals. But again, they didn't have joints. When you do have a gout flare, it's associated with severe joint pain, swelling, redness of the joint. The joint's going to feel warm to touch. Usually, when you have a gout flare, it's going to maybe affect one or two joints during a flare, but it can actually affect any joint in your body. Now, it often occurs in people over the age of 40, but in males, gout can occur at any age, usually after puberty. So once a male goes through puberty, they're at an increased risk of getting gout. Um, I've got 18-year-olds, 20-year-olds, 30-year-olds, and 80-year-olds with gout. Now, it's a little bit different in females. In females, it is very uncommon to see gout in a premenopausal female. But once a woman goes through menopause, excuse me, they have the same risk of developing gout as in men. Gout attacks are often sudden and severe. A lot of times I hear this from my patients all the time. Hey, I went to bed feeling great, and then in the middle of the night, I woke up with this severe pain and swelling and redness in my big toe. And that's usually how gout presents. It oftentimes the flare starts in the middle of the night or early in the morning on awakening. Next slide, please. So what is uric acid? Well, uric acid is actually a substance in your body that is created when your body metabolizes these substances called purines. So these purines are converted into uric acid in your body. So what's a purine? Well, a purine is a building block of your body that it normally produces, but purines are also found in foods and drinks that we're going to talk about in more detail. So what happens if you have all of this purine in your body, the body converts it to uric acid. Now, normally this uric acid is dissolved in the blood, and then it's eliminated through your kidneys, through your urine. But in people with gout, they often have a high uric acid, and that's usually because your kidneys have difficulty getting rid of the uric acid efficiently enough. And so we start getting this buildup of uric acid. And about 80% of patients with high uric acid or gout is because their kidneys can't get rid of it well enough. And there's about 10 to 20% of individuals for various reasons who might overproduce gout. But that, again, that's not very common. Now, when this uric acid builds up in your blood and when it becomes at a certain level, what can happen is that the uric acid precipitates out of the blood and forms crystals. And what then happens is that these crystals can deposit into the joints, they can deposit into the soft tissue around the joint. And actually, they can deposit in any part of your body. And we're going to talk a lot about that. So how I like to kind of visualize that is like if you're down in the South and you like sweet tea, you put sugar in it and you stir it and stir it and stir it and it dissolves. But if you put too much sugar in the tea and you try to continue to dissolve it, you won't, and you kind of see the sugar crystals in the sweet tea. So that's very similar to what we're talking about when we're talking about uric acid crystals in the blood. If there's too much, it precipitates out and forms these crystals. Next slide. This is actually what gout crystals look like underneath a microscope. This was fluid that was taken out of a joint, and you can see these thin, sharp, needle-shaped crystals. And the crystals are either blue or yellow, depending upon how the microscope is oriented. But again, can you imagine just thousands of these crystals in your joint, and you can get a better understanding of why gout is so painful. Next slide, please. So we talked about that gout is an arthritis. Now, I'm an older rheumatologist. I did my training in the 1900s, believe it or not. And so when I was trained on how to look at gout, we thought that gout was just a peripheral arthritis, meaning it affected the hands, the wrists, the knees, the elbows, feet, and ankles. And it was just a type of arthritis that people would have episodic flares. But over the last 10 years, we have a much, much better understanding of gout. And gout is not just a chronic, destructive, inflammatory arthritis. Gout is a systemic disease. And when I say systemic disease, that means it affects other organ systems. We know that gout and high uric acid is an independent risk factor for cardiovascular disease. We're talking about heart failure, stroke, coronary artery diseases, peripheral artery disease, hypertension. And if you have uncontrolled gout, you're at a 2 times increased risk of dying from complications from that heart disease. We know that it's an independent risk factor for chronic kidney disease and type 2 diabetes. And if you have tophi, and what a tophi is, that's here on this lower right-hand corner where you see that finger with that mass on it, that's a huge collection of uric acid crystals. If you have visible tophi like that, that increases your risk by threefold. So that's why it's so important for us to make a correct diagnosis of gout and treat it aggressively. It's just not intermittent joint pain. We have now found that gout crystals or uric acid crystals have been found in every single part of the body except for the brain. We've seen it in coronary arteries. We've seen gout crystals in the kidney, in the eye, in the prostate, in the abdomen, in the stomach. So again, it is a systemic disease. I treat my gout patients just as aggressively as I treat my patients with lupus and rheumatoid arthritis because it is the systemic disease. Next slide, please. Now, there are some myths about gout that we want to prove that are false. Gout is rare. Gout is not rare. Gout is the most common type of inflammatory arthritis. Now, when I talk about inflammatory types of arthritis, we're talking about arthritis that causes significant inflammation in your joints, like rheumatoid arthritis, psoriatic arthritis. And again, gout is the most common type of inflammatory arthritis. It's not the most common type of arthritis, that's osteoarthritis. And that's the kind of arthritis that we're all going to eventually get as our joints just start wearing out. Another false statement about gout, it only affects obese people. Gout can affect people of all sizes, all shapes, all ethnicities, all genders. But being obese can increase your risk of having high uric acid and gout. Gout only affects the big toe. Now, that's one of the most common joints we see gout attacks in, but like we talked about previously, gout can affect any single joint in your body. Gout is a man's disease. Well, we already talked about that. You can see gout in both men and women, but in women, again, it's usually after menopause. Next slide, please. So what are some facts about gout? We said it's the most inflammatory type of arthritis. It affects about 8.3 million Americans. And I really think that that number is probably a lower number. I think it probably affects a whole lot more. But when we talk about gout, gout is an episodic disease. You'll have a flare. The flare goes away in a few days or a week or two, and then you feel good. And so a lot of people don't go to the doctor because they know it's going to get better. So I think that's probably even a larger number, but that's still a whole lot of people. Only 10% receive the right treatment. As a rheumatologist, gout is the most mismanaged diagnosis I see. And it's not the primary care provider's fault. It's not the podiatrist's fault. It's not the emergency room physician's fault. It's just that they weren't properly trained. And so not only are we working on educating patients about gout, I also work on educating primary care providers and podiatrists and other physicians of how to appropriately treat gout. Only 1 in 5 know that a family history is a risk factor for developing gout. Gout does run in families. 1 in 4 frequently misses work because of gout. I can't tell you the number of patients I've had that their gout was undertreated before I started seeing them, and they were missing days and weeks and even months of work, almost losing their job. But once we get you on the appropriate therapy, we should significantly improve your life. And speaking of that, 1 in 4 feel like gout does control their life. We have great medicines to make sure that this isn't the case for you. If left untreated, gout can lead to complications such as kidney disease. We talked about the heart disease. And then also, again, it can completely destroy your joints. Next slide, please. So what are the risk factors for developing gout? Well, we know genetics. It does run in family. Abnormal kidney function, and Dr. Green is going to definitely talk about that in more detail. If you're obese, if you're sedentary, if you just don't get up and exercise, that can increase your risk of having a high uric acid and gout. And then regular consumption of high purine foods. And these are foods like red meat, steak, shellfish, shrimp, scallops, lobster, all that good stuff. And then drinking alcohol. And it's not just beer, it's beer, wine, or whiskey. And I kind of think that alcohol is a double whammy because not only is it high in purines, it also decreases the kidney's ability to excrete uric acid. Now, one of these things that's also can be converted to uric acid is high fructose corn syrup. And what contains high fructose corn syrup? Well, everything that you drink that's not diet. So your regular Cokes and Pepsis and 7-Ups and all of those, those all have high fructose corn syrup. Your juices, a lot of your juices have high fructose corn syrup. So again, that can increase your risk of having high uric acid and gout flares. We already talked about age and sex, pre-existing ailments, hypertension, chronic kidney disease, the metabolic syndrome, recent trauma. When I was doing my training in the military at a military hospital, I would often get referrals in the hospital because they're having a gout attack while they're being hospitalized. And a lot of that's because of their IV fluids that they're getting. They're changing that uric acid level, and that can trigger a gout attack. And then medications. There are certain medications that can increase your risk of hyperuricemia and gout. Next slide, please. These are some of the high gout attack triggers for flares. As again, it's if that uric acid is really high in your blood, if you have changes in your uric acid level, this means going out and, eating an all-you-can-eat shrimp dinner with drinking 6 beers, that can increase your uric acid level and cause a gout attack, but also decreasing your uric acid level. If you get IV fluids for whatever reason, that can dilute your blood, which causes a decrease in your uric acid, which can trigger a gout attack. Drinking alcohol, like we talked about, and then the surgery. Usually when you have a gout attack, like we talked about, it comes on very sudden. The most severe symptoms occur within the first 12 to 24 hours. Oftentimes it affects the big toe or the foot, and that's based upon your body temperature. We can definitely talk more of that if we want to. And again, you have severe pain, swelling, redness. It's warm to touch. It's so severe that one of the classic descriptions that I hear is that when I go to bed, just even putting the sheet on my big toe causes severe pain. Gout typically in the beginning is self-limiting, meaning that when you have a gout flare, it may last a few days to a few weeks, even without treatment. But even when you're not having that gout attack, when you're not having that red hot swollen joint, there is still uric acid crystals in that joint, which is still causing destruction of the joint. So even though it's episodic, and sometimes you're pain-free, the gout could still be causing damage to your joint. So again, it's so important to start aggressive, appropriate therapy. As gout goes on being untreated or suboptimally treated, it can affect more joints. It can, again, cause those systemic manifestations. And then eventually it's going to cause damage to your joint where you have chronic joint pain 24/7. It's no longer episodic. Next slide, please. In 2024, we should never see pictures like this ever again. We should not, and where all of you see these little lumps and bumps and masses, this is all tophi, or a collection of uric acid crystals. With the great medications we have today, again, we should not see this. But guess what? I still see it on a regular basis because these patients have been undiagnosed or suboptimally treated for their gout. Next slide, please. So, how do you treat gout? This is what I really like to talk about. And it's actually very simple. In a gout, we know what we have to do to successfully treat gout. It is very, very simple. We have to get your uric acid level below 6.0. If your uric acid level is not below 6.0, your gout is not being optimally treated. Now, in some patients, we need to go even below 6. We may need to go 5 or 4 or 3. But again, we have to get it below 6. Now, when I talk to my patients about treating gout, I say there's 3 phases of treatment. The first phase of treatment is when you're having that acute gout attack. And there are different medicines that we can give you when you're having an acute attack. We can give you non-steroidal anti-inflammatory pain medicines. Dr. Green's probably shaking her head because no nephrologist likes NSAIDs, but these are the medicines like ibuprofen, naproxen, indomethacin, Celebrex. There's a whole, yeah, exactly. There's a whole list. You gave me the thumbs down. There are a whole list of non-steroidal anti-inflammatory drugs that you can use to treat an acute gout attack. You do not have to use indomethacin. I have not prescribed indomethacin in over 20 years, but a lot of ER physicians and primary care providers think that that's the best non-steroidal for gout. But again, a lot of our patients can't take NSAIDs because of their kidney disease and for other reasons, or maybe they have a history of a peptic ulcer. So non-steroidals you can use, but again, they're probably not the first line of therapy that in a lot of our patients. You can use colchicine. We've been using colchicine for over 2,000 years to treat gout. It's very simple. It's a very simple dose. Colchicine comes in a 0.6 milligram tablet. At the first sign that you're having a gout attack, you take one, and 1 hour later, and then you're done. And then you can use steroids, and there's different ways that you can use steroids to treat the acute gout attack. You can you can take steroids by mouth. You can get intramuscular steroid injection for the pain and the flare, or you can have a steroid injected into the actual joint that's affected by the gout. But again, sometimes we got to be careful with this because of patients with diabetes. Now, again, this is the treatment for when you're having an acute attack. And what I emphasize to my patients, these medicines, the NSAIDs, the corticosteroids, the colchicine, they are just treating your symptoms. They are not doing anything to treat your underlying disease. So the second phase of therapy is to start you on a medication to lower your uric acid, to get it below 6.0. And there's several medicines that we can use for that. We can use allopurinol or febuxostat. Those are both what we call xanthine oxidase inhibitors. There's a medicine called probenecid. It's really not the standard of care, and you have to have normal kidney function in order for us to use probenecid. So I very, very rarely use that medicine. The only time that I actually use it is when an insurance company makes me use it because they're denying other medications. And then there's pegloticase or Krystexxa. Now, the allopurinol and the febuxostat, how they work is they decrease the body's ability to convert those purines into uric acid. So we're stopping the production of uric acid levels, the uric acid. But if you've already made a whole bunch of uric acid, it's still all throughout your body. Now, the pegloticase or Krystexxa, this has been actually a great medication because what the pegloticase does is it converts the uric acid into allantoin, which is readily excretable by the kidneys. So 100% of the uric acid, when it's converted into allantoin, is excreted through the kidneys. So that's been actually a very, very beneficial treatment for our patients with gout. And the way that I like for us to look at it, let's say that you have gout and you've got these tophi and your body is just filled with gout. And let's say your body's like a bathtub and it's just filled with uric acid and the faucet's turned on. And your body is getting more and more and more and more uric acid level because the faucet's still turned on. What the allopurinol and the febuxostat do, the Uloric, is it turns off the faucet. So your body's no longer, your bathtub's no longer getting the uric acid, but you're still stuck with this bathtub full of uric acid, or your body's still full of this uric acid. What the pegloticase does is it pulls the plug to allow all of that uric acid to leave the bathtub. Now, so that's the second phase of therapy. That's how you lower your uric acid level. Now, the third phase of therapy, and this is where a lot of other physicians make the mistake. If I were to put you on allopurinol or febuxostat or pegloticase to lower your uric acid level, I'm very probably going to cause you to have a gout attack. Because when you lower your uric acid level quickly, it causes what we call an immobilization flare, where you actually have a gout attack because we're putting you on this medicine. Well, that's bad. You're not going to continue taking the medicine because it's not helping you. So the third phase of therapy is that you have to be started on a medicine in addition to one of these uric acid lowering medications to prevent you from having a gout attack as you're lowering your uric acid level. If I could see a show of hands of how many people had a gout attack after starting one of these medications, I'd love to see that. So what you do is you start a medicine, and the medicines that we use, and we call this prophylactic therapy. Again, this is preventing a gout attack as you're lowering your uric acid. And this medicine is only temporary. You start the medicine and you can use low-dose NSAIDs, you can use colchicine, one a day, or you can use low-dose steroids. And what you do is you stay on this medication until your uric acid level is below 6 for 3 months. Once your uric acid level is below 3 for 6 or below 6 for 3 months, then you stop this prophylactic therapy, but you continue the medication that you're using to lower the uric acid level. Next slide, please. So other ways to manage gout: healthy habits, exercise, eat healthy, avoid those foods that are high in purine, maintain a healthy weight, drink plenty of water to flush out the uric acid. So these lifestyle modifications are great, but typically patients with gout are going to need medications. Studies have shown that being the most compliant patient, doing all of these things, is going to lower your uric acid level by maybe 1 point. So if you're at a 9.0 uric acid and you're doing all of these healthy things, you're only going to decrease your uric acid to 8. And so we're not at that below 6 level. These things are all important, but again, we really need medications to optimally treat gout. Now, one of the big myths I wanted to talk about also is you having gout is not just your fault. A lot of my patients avoid seeing a doctor because they have this stigma that the doctor is going to blame them for their gout. It's not just your fault. There are other reasons why you have gout. So go to the doctor, get diagnosed, and get appropriate treatment. Next slide, please. So There's no cure for gout, but it is very, very treatable. Again, diet matters, but again, you're gonna need medications to optimally treat your gout. We do not stop your uric acid lowering medications without consulting your diet, or excuse me, your doctor. Also, you do not have to stop these medications if you develop a gout flare. So next slide, please. The best way to manage your gout, know your disease, learn about it. I applaud everybody who's on this webinar. Track your records, track your symptoms, find out what exacerbates it, what makes it better. Those are all things that you can do to help the physician optimally treat your gout. Next slide, please. So a couple of questions that have been asked. How has the prevalence of gout changed over the past decade? And what factors do you attribute to these changes? Well, it's sad to say, but I think that our society has become unhealthy. I think that there are a lot of Americans that aren't eating correctly, and eating healthy is expensive. It's a lot cheaper, or it used to be, to go to McDonald's and eat a Big Mac than it is to eat healthy salads and all the good healthy foods. But we have to do that. And again, I don't think Americans are exercising as much. We know that there's an increase in patients who are overweight or obese. So I think it's just our unhealthy lifestyle that's really seen the prevalence of gout increase. And I also think that we've gotten smarter about gout. We now know that it is a systemic disease, and we know how to treat it early, and we know how to diagnose it better. What are some of the emergency or emerging research areas or treatment for gout? Well, again, back in the 1900s, for me to definitively diagnose gout, I would have to stick a needle in your joint that's already extremely painful, pull out fluid, and look at it underneath the microscope. Well, now we have great technology. Now, it's not available at all of the imaging centers, but there's a lot of imaging centers that now have this technology called dual energy CT, or dual energy CAT scan. And it's just a regular CAT scan that you get of a certain part of your body that's bothering you. And then they have computer software that manipulates the data where you can actually see the gout crystals on the imaging. It is fantastic. That's how we now know that gout is a systemic disease, and that's how we've made the diagnosis of seeing gout in the kidneys and the heart and the eyes, is through this dual energy CT. As far as the treatment, the peglotica case that I was talking about, that you're pulling the tub out of the bathtub and all of the uric acid medicine is leaving your body, that has been life-changing for a lot of my patients. I mean, it's probably one of the most significant medications that's been made available to me and to treat my patient, regardless of the diagnosis, whether it's rheumatoid arthritis, lupus, gout, or whatever. This has been life-changing for a lot of patients. Those big, massive tophi that you see on the toes and the fingers, they can dissolve away in months as opposed to years with using allopurinol or febuxostat. So again, all very important strides we've made in optimally treating gout. And there's ongoing research. They're trying to find even better medicines and easier ways to make the diagnosis of gout. Next slide.
All righty. Well, we want to thank Dr. Rennie. We see the Q&A on our side and it is blowing up. You guys are super engaged. We will have him come back during our Q&A section to give us a little bit more information. And I'd love to now introduce Dr. Jamie Green. As we transition from rheumatology perspective and the Arthritis Foundation focus on managing gout, it's important to recognize how interconnected these conditions are with kidney health. Gout isn't just an isolated issue, it has direct implications for kidney function, particularly in patients already managing chronic kidney disease. This is where the collaboration between the Arthritis Foundation and the American Kidney Fund becomes so valuable. Both organizations provide robust complementary resources designed to offer patients a holistic view of their health. Now we'll turn to the nephrology side to get a better understanding of the impact of chronic kidney disease and how managing kidney health can play a crucial role in addressing gout and improving overall patient outcomes. Introducing Dr. Green.
Thank you. Thank you very much. Yes, I'm very excited that this is getting a lot more attention. I see patients with the gout and kidney disease all day long, and I get so many questions about it. So I'm happy to have the opportunity to talk in more detail about that. Next slide, please. Okay, so first off, what do your kidneys do? And how does this relate to gout? The kidney's main job, many of you may have heard people say the kidneys clean your blood or they remove the waste products from your blood. Your kidneys work as a filter. They're two bean-shaped organs that sit kind of in the lower part of your back, underneath the deep muscles, and they remove waste from your blood. They remove extra fluid from your blood, and that makes urine. So that's the liquid waste that is removed from your body. And in this process, they're controlling the chemical balance and the electrolyte balance in your body. Things like sodium, potassium, phosphorus, even the acid level in your blood, and things like uric acid. So they help control your blood pressure also. A lot of people don't realize. I get patients referred to me with high blood pressure, but they have normal kidney function. They want to know why they're seeing a kidney doctor, because the kidneys help regulate your blood pressure. They help keep your bones healthy. And they also help your body make red blood cells. They actually make a hormone that tells your bone marrow to make your red blood cells. So they have a lot of important jobs. Next slide. So in speaking of chronic kidney disease, as you heard, patients with kidney disease, it's one of the main risk factors for, well, maybe not the main one, but it is a risk factor for gout. Having patients with kidney disease are at an increased risk, I think about twice the risk of having gout as the general population or patients that don't have kidney disease. But the reverse is also true, in that gout can actually cause kidney disease. And so this is all related to how the kidneys work. So because the kidneys help get rid of uric acid in the body, when your kidney function is reduced, uric acid can build up, and then that leads to gout. And if you have gout and high levels of uric acid, over time, that uric acid, you saw those pictures of all those crystals can then filter through into the kidney and then damage the kidneys. So it works in both directions. But what is kidney disease? You may say, oh, well, if kidney disease is a risk factor, I have gout. What is kidney disease? Maybe you don't know, or maybe you have kidney disease and you know it already. But it's pretty common. Chronic kidney disease just means that your kidney function is reduced for more than 3 months, and it doesn't go away. So that's why we call it chronic kidney disease, reduced below the normal level for more than 3 months. The most common causes are diabetes and high blood pressure, but gout is actually one of the causes of kidney disease as well. Okay, next slide. Medications are also important in this kidney gout connection. Many patients with kidney disease take medicines that can cause gout attacks or contribute to gout. So certain water pills, and then certain blood pressure or heart medicines like beta blockers or ACE inhibitors or ARBs. So diuretics are typically the thiazide diuretics like hydrochlorothiazide. Beta blockers are things like metoprolol, or Toprol is the brand name of that. Atenolol, some people take. And then ACE inhibitors and ARBs are things like lisinopril, losartan, valsartan. Those are medications that you may be on that could increase your risk of gout. They increase the uric acid level in the blood. Now, I'm not saying that if you have gout, you shouldn't take these medicines, because oftentimes they are very necessary. But it's worth a look in someone who has refractory gout, that if there are alternatives, you might consider switching to something that doesn't increase uric acid in the blood. Next slide. So gout can actually be a warning sign of kidney disease. It's really important to know that patients with kidney disease usually have no symptoms until it's very late. The symptoms of kidney disease are often very nonspecific and don't happen until your kidney function is significantly reduced. So sometimes it's helpful to, something as simple as knowing that you have gout could be an indication or a trigger that, hey, I should have my kidney function checked. Also, some medications people take for gout can harm the kidneys. So if you have gout, it's really important that you be screened for kidney disease. And then some of the medications that we use to treat gout need to be adjusted based on your kidney function. So for all of those reasons, if you are a patient with gout, you should ask your doctor for 2 tests if you don't know the results already. And that's at the bottom of the screen, the eGFR, which is the estimated glomerular filtration rate, and the ACR, which is a urine test. That's the albumin to creatinine ratio. Those 2, and there's even a panel that some labs offer called the kidney panel. But if you can just ask your doctor and just make sure. They should be checking these things already, but if not, you should ask for them, or at least, and you should also know the results so that you yourself know what your kidney function is. Okay, next slide. So the American Kidney Fund is, if you don't already know, they're co-sponsoring this webinar. They are a national organization that is fighting on all fronts to help reduce the burden of kidney disease. They are an amazing organization. They do a ton of patient education and advocacy, and they offer financial assistance to patients. So they really do help patients in every stage of kidney disease through all these mechanisms. They just do a wonderful job. And the next slide. So they have a campaign called Goutful. That's their educational campaign about gout, which provides resources for patients to learn more about gout. Next slide. And the key messages of this campaign are that, and hopefully we've hit a lot of these already, but in case not, these are 5 key points about gout and the kidney. So number 1, kidney disease can lead to gout, but gout may lead to kidney disease. Number 2, kidney disease is one of the leading causes of gout. Number 3, and so much so that we treat patients with gout and kidney disease specifically, if we know that, because it's a risk factor. Gout is a type of arthritis that causes pain and swelling in your joints that Dr. Rennie did such a beautiful job of talking about. Number 4, gout is caused by having too much uric acid in your blood. That's important because it all relates to the uric acid, either too much being produced or not enough not being able to get rid of the uric acid in your body. And then gout may be prevented through lifestyle changes and medicine. Next slide, please. So if you go to the American Kidney Fund website, the specific page for gout is listed there, kidneyfund.org/gout. There is a ton of information there and resources for patients. They have both downloadable guides as well as print. You can print the guides and trackers related to gout. There's quizzes, patient videos, etc. There's even information about medications to treat gout and diet. People always have a lot of questions about diet. So there's information about things that you should eat, or things that you shouldn't eat, and things that you can eat that would be helpful. So it's a really amazing resource. Please check it out if you can. Next slide, please. Okay, so that was a quick overview, I guess, of gout and the kidneys. These are some questions. Does early gout treatment help prevent kidney problems? And yes, it can if untreated. If patients who have high uric acid levels it can contribute to kidney disease progression or development of kidney disease. So if you have gout, it's important that you treat it and keep your uric acid levels within a target range. And if you ignore it, yeah, same thing. It can cause permanent damage. So it is really important that you treat your gout to prevent any complications. And I think Dr. Rennie did a beautiful job of talking about the fact that a lot of those severe complications that we used to see with the tophi and things on fingers and all these affected organs, we rarely see that anymore because we have such effective treatments. And many of my patients come to me and say, well, they have refractory gout, and they say, well, my doctor told me that I can't take any of the medicines because I have kidney disease. And that's absolutely not true. So there are certain medications like nonsteroidal anti-inflammatory medicines, the NSAIDs, that we don't like to use in patients who have kidney disease. Sometimes it is appropriate, depending on your level of kidney function. But there are, you can use colchicine, and prednisone is a very effective treatment option for patients. So there definitely are treatments to both reduce the pain, but then also prevent. So allopurinol can be used in patients with kidney disease. I think I saw a question about that in the chat. It is not toxic to the kidneys itself, but it does need to be adjusted based on your kidney function. You need to start with a lower dose. So just some important things to point out there. And then next question, are there specific dietary or lifestyle modifications in individuals with both gout and kidney disease to be aware of, and how can they help manage both conditions? So a lot of the things you heard Dr. Rennie talk about, like avoiding animal protein, like red meat and seafood, and increased fluid intake, weight loss, avoiding alcohol, all of those things are excellent for people with excellent for your kidneys, even if you don't have gout. So those are kidney protective strategies in general. Following a plant-based diet has been, patients who follow a plant-based diet tend to have a lower risk of kidney disease. So all of that together can both reduce your risk of gout and chronic kidney disease.
Awesome.
Thank you.
Well, we are going to go ahead and summarize our presentation from our wonderful nephrologist and rheumatologist, and then we're going to go into our Q&A. But what I wanted to make sure I kind of wrapped up this presentation by saying, you can have a comfortable life with gout. Gout and kidney care are interrelated and interconnected. They play off of each other sometimes. Sometimes one is the cause of the other. But early diagnosis and treatment are crucial. The earlier you know, the earlier you can get your healthcare team together and you can start working on some treatments. Lifestyle plays a significant role. Let's remember in gout, sometimes it is genetic. Sometimes the working out and the eating well, it will reduce some of your problems, but especially with kidney disease, it can be a helpful factor. And regular checkups are essential. You don't have to deal with this all by yourself. Please include your doctors, and all of those together will allow you to live a comfortable life with gout and if you have kidney disease. So I'm going to ask that Dr. Rennie join us on screen. And we have some questions that you guys sent over when you registered that we would love to kind of go through as well. Give me a second to pull those up. All righty. My very first question is going to go to Dr. Green. So Dr. Green, what are the early signs that gout is affecting kidney health, and how can patients monitor this?
Yeah, the earliest sign if gout or uric acid is affecting the kidney would be a reduction in your kidney function. So that would just be, you should really just want to be aware of your kidney function and make sure that you're being screened and that you're getting you should have at least an annual blood test and urine test to look for your kidney function. What that test is called the GFR, and the urine test is called the ACR, or albumin to creatinine ratio. So those two tests. Now, I would say that gout, uric acid damage to the kidney doesn't usually cause protein in the urine. Probably the most important thing is to know your blood level. So I would say just following your kidney function over time, and if it starts to go down, then that's something to take note of.
Awesome. We're going to go over to Dr. Rennie. All righty. So let's ask, is there any new research on supplements or diet changes that can help with a current flare-up or flare-up prevention?
Well, we talked about a lot of the medicines, and that's very important. But lifestyle modifications, like we said, exercise, maintain an ideal body weight, healthy diet that's low in purine. Those are all things that are beneficial. Other things that studies have shown is that sometimes cherry juice. There are studies to show that eating cherries or drinking cherry juice can be beneficial. If you do the cherry juice, you need to make sure that it also doesn't contain high fructose corn syrup. There's studies to show that drinking coffee can be beneficial. I will never get gout then. There's also studies to show that dairy products can help also. And so those are things that you can do. One of the things that I wanted to talk about, what Dr. Green was talking about, the medications, those are all very, very important. But there is one ARB called losartan that is actually shown to be beneficial and can help decrease uric acid. So if your primary care provider or nephrologist can switch some of those medicines that may be beneficial, that could help with the gout also.
Awesome. So I want to go over to Dr. Green again. How can gout patients collaborate with both rheumatologists and nephrologists to create an effective, cohesive treatment plan?
I think that you really want to have a team-based approach and to make sure that everybody is communicating. And so depending on where you receive your care, that can be more can be easier or more challenging. If you're all in the same health system or clinic area and you have a rheumatologist and a nephrologist and they can share their findings easily, then it's probably automatically happening. But it's sometimes more difficult and you may have to rely on your primary care doctor, or you may want to just make sure that they are sending each other their communications. So that they know their contact information or how to get in touch with each other.
Perfect. So if you are a patient and you have Dr. Rennie and Dr. Green, you should make sure that they each are aware of each other, making sure that those doctors can connect. I'm going to hop back over to Dr. Rennie. So there's a lot of commentary in the chat of people saying, hey, my treatment isn't quite working that I'm on. What are some of the red flags or signals that you have with a patient that comes in where you're thinking, hey, maybe we should change out the treatment plan?
It's actually very, very simple. If you're continuing to have gout attacks, even if your uric acid is below 6, if you're still having gout attacks, I saw one person in the chat that said their uric acid is still their uric acid is 4.5 and they're still having gout attacks. Well, we need to put you on a medicine to get it down to maybe 4 or 3. So if you're still having gout attacks despite a low uric acid, that is a reason to escalate therapy, and that may be a good indication for the pegloticase. Or if your uric acid level is still above 6.0, again, it's not being optimally treated, because even though you may not be having a gout attack, if that uric acid level is greater than 6, those uric acid crystals can still be in the joint fluid and still be causing damage. So those are the two main things to escalate therapy: continued gout attacks, or your uric acid level is not less than 6.
Awesome. So I have a question for Dr. Green to maybe switch gears a little bit. What is your favorite thing about being a nephrologist? Many times on our webinars, we talk to orthopedic surgeons, we talk to rheumatologists, physical therapists. We have a nephrologist today. So, what is your favorite part?
Sure. That's easy, is my patients. I think that, I mean, I love the kidneys. I think they're fascinating organs. I've always, from medical school till now, I just think that they control so many things in the body and they regulate so much. And so they're so important that when things aren't working well, I love to be able to help my patients. And other doctors often don't understand the kidneys very well. So it makes it so that, yeah. So when patients come to me, I feel like I can really help explain things and in a way that probably their other doctors can't. So I love being able to educate and provide resources and very often reassure patients that the kidneys aren't as scary as they think they are, and that there's a lot we can do to protect them and treat them.
That makes
And I
me so
have very
happy.
good relationships with my nephrologists.
Yes, we work very closely with rheumatology, actually. So we like working together.
Awesome. So that actually gives a great segue to the question I want to ask you, Dr. Rennie. So we say we have a patient who is having a gout flare. They are having that pain that feels like they just were hit by a truck. A lot of times those patients start to get down mentally. They feel alone. They feel kind of just sad about their situation. What is a word of encouragement that you give your patients when they just seem kind of just lost about their diagnosis?
I will make you better, 100%.
That is a perfect answer.
With gout.
Okay, so he may not be able to help you if you do not know how to boil rice. But if you do have gout, Dr. Rennie over in Texas can help you out.
Yeah,
I do have a follow-up to that one, Dr. Rennie. If you can make them better, what would you say is that first step? Is it to come see your doctor? Is it to do research? What would you say?
so ask the question again.
Yes. So if the patients know that you're going to make them better, what would be their first line of defense? Do you want them to go to a doctor first? Do you say that they should maybe get some research first? What do you say the first line of defense if you think you're having a gout flare is?
I think that the most comforting thing that I tell them is that, like Dr. Green knows the kidney, I know gout, I know how to treat it. you know, you are at the right place. I am going to make sure that your gout is optimally treated. We know how to do that. And that's one of the beautiful things about gout. And one of the reasons I like being a rheumatologist is that, yeah, you can treat your patients' hypertension and their kidney disease and their heart disease and their high cholesterol and save their lives. And their patients are grateful that they're still living. But man, if you take away their gout, if you take away that gout flare and they don't have any gout flares and they're not missing work and they're not having pain anymore, that is a very happy, gratified patient. And so that's one of the reasons I went into rheumatology, is because I like taking away people's pain and discomfort.
That's wonderful. Well, as we close out our Q&A moment, do any of you have maybe some closing words or kind of advice to give our attendees?
One of the things, I'm looking through some of the questions here, and there's a lot of questions about rheumatoid arthritis and gout and osteoarthritis and CPPD and just different types of pain. And it's like, look, I'm still having pain. So one of the things, and this is where a rheumatologist can come in and be very, very beneficial. Patients with gout can have osteoarthritis. They can have rheumatoid arthritis. They can have fibromyalgia. They can have CPPD. And what that is that's a different type of crystal. Gout is uric acid crystals, and CPPD is calcium pyrophosphate crystals. Completely two different diseases, different risk factors. We do not have any medicines to decrease calcium pyrophosphate in the body like we do with the uric acid. And so what's important is to and what the rheumatologist needs to do is determine, is this pain due to your gout, or is it due to your rheumatoid arthritis, or is it due to your osteoarthritis? Because the treatment for all of those are going to be different. And so, I'm just seeing a lot of questions about, hey, I've got CPPD and I've got gout and I've got osteoarthritis. So we've really got to figure out what is causing the pain. Is it 100% gout, or is it maybe 50% gout and 75% or 50% osteoarthritis? And one of the other things I saw here is, somebody asked, are there seafoods that are low in purine? And the answer is yes. And one of them said that they saw a lot of pictures of salmon in the presentation, which I didn't pick up, but salmon is actually low in purine. So maybe that was a tuna or something. But salmon, tilapia, flounder, cod, canned tuna, anchovies, those are all seafood that's low in purine. So you can eat those.
Yes, we wanted to make sure that you guys know, eat your salmon.
Eat your salmon, yes.
Anything else for you guys before we head on? Thank you so much. So now let's go ahead and wrap up this presentation by talking about some of the resources. So we heard from Dr. Green about all the amazing resources from the American Kidney Fund, but we want to double down on the fact that you are not alone. We have resources, information, and things that can help you get better and learn more about yourself and your disorder. So we really do focus on at the Arthritis Foundation on connections and empowerment, advocacy and access, and science and research. If you have any additional questions, we have an Arthritis Foundation helpline. The number is on the screen. We also have where you can send an email. If you want to find more about that, arthritis.org/helpline. We have people on staff 24 hours to better understand your disease, help you interpret your insurance coverage, connect with other people just like you, and get involved and volunteer. We wanted to make sure that we highlight our gout patient education, and that is on your screen, our Gout Hub. When you go to the main page, you'll be able to see we have sections for understanding your gout, gout treatment, and more about gout. On the website, we also have information about kidney disease because they are so interrelated. A couple of additional support resources because we want to be the place that you come to get some help. We have a webinar coming up actually next week. It is the link see how we do a bunch of collaboration. So we have a link, arthritis, diabetes, and heart disease, which Dr. Rennie talked about in terms of comorbidities. That's going to be next Thursday, same time. You can sign up at the web address below. We have connect groups. We have a gout connect group occurring November 9th. So think of a support group. You get to come spend time with other people that have similar backgrounds, similar lifestyles, and of course, a disease that you guys can kind of figure out how to manage together. And we have podcasts when you're driving home for work or you're going to grocery shop to get some of that salmon or to get some wonderful cherry juice. Play that in your speakers. That said, thank you so much for joining us. We hope to see you at our next webinar. Thank you again, Dr. Green and Dr. Rennie, for your expertise, and we hope to see you again soon.